Hey guys, if you guys need to zoom in on the video or change the quality, do so. But pretty much what I'll be doing is going over every topic in the study guide, or I feel like that is very more important for the exam on Monday, and pretty much like the big points for each section. So first we'll be going over diabetes. So there's type 1 and type 2. Type 1, we know that they're born with it and the insulin doesn't produce, or the pancreas, sorry, there's no insulin production. And then type 2 is whenever they can develop diabetes. So through obesity, sedentary lifestyle, metabolic syndrome, which is hyperglycemia, hypertension, central obesity. So central obesity is going to be 40 inches for males, 35 inches for females. What else? Central obesity, hyperglycemia, hypertension. I feel like there's one more and I keep forgetting it. Oh, sedentary lifestyle. Like they don't do anything, I'm pretty sure. But pretty much this is where the pancreas doesn't produce enough insulin. All right, and then diabetes can cause hypertension, cardiovascular disease, strokes, PVD, kidney disease, neuropathy, and retinopathy. And then this is most common in Black people, Indigenous people, and Hispanic people. All right, so some screenings that we would do as a nurse is we'll screen someone who has a BMI greater than 25, and if their blood pressure is greater than 140 over 90, and if their blood glucose or their A1C is greater than 5.7, or if they have an impaired glucose, either fasted or tolerant. So for things you want to tell them kind of what to eat are carbs, protein, unsaturated fats, and unsaturated fats. All right, for insulin, so insulin, you can give it to type 1 and type 2, but for type 1, you only give insulin. They need insulin because if they don't have insulin, their sugar is going to be super high. So there's rapid insulin. Well, I put the acronym LAG or LAG, standing for Lispro, Aspart, and Glucosamine. And this pretty much has a 10 to 30 minute onset, so you want to make sure you give this insulin subcutaneously before their meal to control the postprandial something. But pretty much that means like post carb, so like postprandial sugar or whatever. And there's short insulin, which is regular, right? And you want to make sure you give it 15 to 30 minutes before, then again to control the postprandial state. And there's two types of insulins for regular. So there's U500, which is you only give subcutaneous, right? So if we do the Macarena, they can get it, here, where else? Here, and then like that's it. So the fatty areas. And then U100 would be the subcutaneous and IV. So U100 is subcutaneous and IV. All right, and then for MPH, which is our intermediate, so you want to make sure you give 30 to 60 minutes before meals and at night, and it contains protamine, which is a protein, and you want to only give it subcutaneously. And for MPH, it's not used for postprandial control. It's better yet used just for like balancing out the insulin instead. All right, and then let's see, long insulin, right? So I put DGL, meaning for Detromir, Glargine, and then Lantus. Lantus isn't in the ATI, but Lantus is something that we have learned. All right, so you want to make sure you give it once a day, subcutaneously at the same time. All right, so some expected findings you should see. So a lot of people that have diabetes, they tend to have high blood sugar. So you can see hyperglycemia type symptoms. So they'll have 3 P's, which is polyphagia, polydipsia, and polyuria, sorry. Polyuria, increase in urination, polydipsia, increase in thirst, polyphagia, excessive hunger. They have Kussmaul's, which is the Kussmaul breathing, where they're hyperventilating, trying to expel so much CO2 out of their body. And then they have recurrent infections, also known are just vaginal yeast infections, commonly in women. And then some risk factors can be the metabolic syndrome, like I said, the age. As we age, organs tend to decrease in their function. And then insulin resistance, if we have an insulin resistance, the sugars are going to go high. And then for labs, so we can get the glycosated hemoglobin, which is the A1C. This is the best indicator for average blood glucose. So if they see a text question say, what is the best indicator for average such, you're gonna pick the A1C. Fasting blood glucose, you wanna make sure you postpone anti-diabetic meds except for insulin. Anytime you need to do a type of fasting blood glucose, you still make sure they get their insulin, even though they're NPO. All right, let's see, where am I? Oral meds, right? So we have metformin, the one that's in the study guide. Usually this is given to type 2 patients. You would adjust it if the patient is going through a fasting blood glucose, or if they're going, or if they're on NPO. And you want to make sure they're taking vitamin B12 and folic acid, and they're taking it with food. You know, if they don't take it, then this can lead into lactic acidosis. So you want to watch for lactic acidosis as well. So which that can consist of somnolence, where they have excessive sleeping, sluggish, myalgia, hyperventilation. So that's what it is. And then we have hypo and hyperglycemia protocol, right? So in the ETI, it says, for hyper, they're hot and dry, fruity breath. So you really want to administer insulin and then test the urine for ketones because it can be possible DKA. And then for hypo, you want to place them in a lateral position to prevent aspiration, and then administer glucagon, subcutaneous or intramuscular, if they're unconscious. And you want to repeat every 10 minutes until they're awake. And you want to give 15 grams of carbs. So it'll say like 15 grams of such and such. That's the answer. But if they are awake, then you offer them the foods, you offer them the carbs, you offer them the protein, you offer them the sugar, you try to get their sugar back up. And then you want to recheck the blood sugar every 15 minutes. And also in the ETI, it does says this. So don't get this tripped up with DKA and what the management of diabetes say. So glucagon and dextrose 50% IV is only if they can't swallow. 5% is what you give for patients that have DKA when their blood sugar gets back down to 250 or 200. But that's going to be something different. All right, so let's go over here. So for client education, right? So for insulin, you want to tell them rotate the sites, keep it in different areas so that way they don't develop lipotrophy or lipoatrophy. And then foot care, inspect the feet daily, wash them daily, use mild soap, warm water, use the wrist to test the temperature, use lotion except between the toes, don't go out barefoot, don't be prolonged sitting or standing, remember ABCs and PVD. And then for foods, you want to tell them the 15 grams of carbs, that's one exchange of carbs. Exercise, only exercise if the blood glucose is 80 through 250, never with ketones. And then illness, the biggest thing with illness, you want to check it 2 to 4 hours. Don't get mixed up with DKA and regular diabetes. For regular diabetes, it's 2 to 4 hours. You want to test the ketones for urine, and you want to call the provider if the temperature rises up to 101.5. The blood glucose is greater than 250, leading to possible DKA, and then illness would be greater than 2 days. All right, so some diabetic neuropathy and retinopathy and nephropathy, right? This can develop when diabetes is kind of uncontrolled. So retinopathy, right? You want to make sure they're getting a yearly eye exam, and that they can also have hypoglycemia. Nephropathy, you want to conduct yearly BUN, urinalysis, microalbumin testing, and creatinine testing. And then neuropathy, you want to make sure you're checking the foot care, the urine retention, and activity. All right, so that's diabetes. Let me see. All right, so some complications of diabetes would be DKA and HHS, right? So DKA, that's too much sugar. So pretty much this is also a cause from the increase in hormone production, and some expected findings we might see are the 3 Ps, some weight loss, some GI effects because of the metabolic acidosis that they have, some blurred vision, the orthostatic hypotension. Remember this fruity breath or acetone breath. Kussmaul's, and metabolic acidosis. Those are the three big keys for DKA: fruity breath, acetone breath, Kussmaul's, and metabolic acidosis. And then altered mental status as well. All right, so some info, right? So their blood glucose would be usually greater than 300. Ketones will be positive. Their potassium will be elevated, but once you give insulin, it can be at risk for hypokalemia. And then BUN and creatinine will also be increased. And then from in the study guide, she said to know ABGs. So some ABGs to know for DKA would be metabolic acidosis. So the pH would be less than 7.35, right? The CO2 will obviously be increased because of the carbon dioxide, which is acidic. The HCO3, which is our bicarb or one of the two, would be 0 out of 15, and then bicarbonate would be 1 through 15. And then some nursing care that we would do, right? So in the ATI it says check vitals every 15 minutes, then once stable, check them every 4. You want to start with 0.9 saline, 1 to 3 hours, and if the sodium is elevated, right? So if they have hypernatremia, then you want to make sure you give them a hypotonic solution like 0.45 normal saline. And you want to administer regular short-acting insulin. You want to give 5% once the blood glucose is 250 to prevent hypoglycemia. Not 50, but 5% in DKA. And you want to continue until the acidosis is resolved. And then if they are ill, you want to make sure you check the blood glucose every 1 to 4 hours and don't skip insulin. And you want to tell them, make sure they wear their medic alert bracelet, where they need to drink at least 2 to 3 liters per day, check urine ketones, report if the temperature is 101.5, and then again, like if they're ill for more than a day, report it. All right, so for HSS, right, there's not too much on it, but we do understand that it's an adequate fluid intake or poor kidney function or lack of insulin, and some risk factors can be due to stress, medical conditions like myocardial infarctions, cerebral vascular injury, so like strokes, sepsis, glucocorticoids, beta blockers, calcium channel blockers, and diuretics. All right, so same thing with the expected findings, just a little bit different. So 3 Ps, weight loss, orthostatic hypotension, blurred vision. Biggest thing with this one is different is that they have seizures, myoclonic jerking, which is where there's misfires in the brain, which imitates the shakiness of the seizure. So they're gonna have tremors and they're gonna have mock-like seizures. And the reversible paralysis and mental status is altered. And then, sir, for some info, right? So their blood glucose could go all the way up to or be greater than 600. 600 is crazy. Sodium and the potassium would be low or high. There would be absent ketones and absence of acidosis. Their bicarb would be greater than 20, and their pH will also be greater than 40 or 7.4. So I kind of like to think of it as they're more on the alkaline level more than acidic level, if that makes sense. And you want to make sure you check for dehydration and report changes in mental status. So that's all for diabetes. And then now we're going to move on to thyroid. So for thyroid, we already did the quiz, so it's not too much, or this would be really a refresher. So for hyperthyroidism, we know that the T3 and the T4 is increased and the TSH is decreased. And then through that, we also need to know the negative feedback loop, where the hypothalamus releases TRH, which is a thyroid releasing hormone, which goes into the APG, which is the anterior pituitary gland, which releases TSH into the bloodstream, into the thyroid, which will then create T3 and T4, release into the thyroid gland, and then T4 then becomes T3. All right, so what are some causes of hyperthyroidism or risk factors? So female and age, Graves' disease, thyroiditis, toxic adenoma, drug-induced like iodine and amiodarone, which is very high in iodine, and then toxic nodule goiter. So some expected findings, right? So we know they're going to be up and hyper, right? So they'd be hyperactive, insomnia, so barely getting any sleep. They'll be heat intolerant, so very, very hot. They'll be diaphoretic because of the heat intolerance, so they're sweating. They'll have weight loss with an increased appetite. They'll have diarrhea, menstrual irregularities, and their skin will feel very warm and velvet. and they'll have tachycardia and palpitations, and their eyes they're gonna bulge, so that's called exophthalmos, and they're gonna have goiter, and they have a bruit over the thyroid gland and AFib. And the biggest thing I like to say is they'll look like Wendy Williams with the eyes and the cankles. So they have pretibial myxedema, and it'll look dry and waxy. And they can have dyspnea and hypertension as well. And then some ways for me to remember for the medications, I like to use the acronym BIT. So BIT, I drew some teeth and some big eyes. So that would be beta blockers, as in propranolol, atenolol, and metoprolol. And that's probably gonna go into for the heart situation. So like the tachycardia, the palpitations, other sorts. And then the iodine, so like the Lugos. And for this, you want to make sure they use a straw when drinking, because they can stain the teeth. And then thionamides, right? So this would be the methimazole and the propylthiouracil. And you want to make sure you take it with meals and report any fevers or jaundice. And then some therapy would be RAI. You want to try to make sure they avoid people for 2 weeks and try to excrete the radiation. So don't be around pregnant people, infants. Bathrooms, make sure you flush 3 times. The washroom, make sure you don't wash with the same clothes. Take a laxative. So yeah. And then thyroidectomy, right? So you want to make sure you have a trach kit by the bedside with suction, decreased calcium. So you want to make sure you're looking out for Trousseau signs and Chavex. And you want to make sure you check their voice after, because they can have hoarseness for every 2 hours. And then for the way how you want to position them would be in a neutral position, semi-Fowlers. And then if their calcium do get too low and they do present with those signs I just told you, you want to make sure you have calcium gluconate or calcium chloride ready and available. All right, so for thyroid storm, right? This is when this is a hypersecretion in thyroid hormones. So you want to make sure you're managing airway, administer Tylenol for pain, no aspirin because it can increase the effects, I want to say, or increase the production of TSH, or one of the thyroid hormones. And it'll, I think T3, sorry. And it'll provide, you want to make sure you provide a cool, like, sponge bath. So keep them cool, keep them calm, keep a very calm environment, So yeah. Then moving on to hypothyroidism. So we know it's the exact opposite. So we have increased TSH, decreased T3 and 4. Risk factors kind of stay the same. So females, age, but this time it's due to meds like not iodine. I think iodine. Is it? Yeah, like iodine and radiation. So some expected findings, right? So we got the lethargy, so they're very low, depressed. They got fatigue. They're very cold. They're cold intolerant. They have constipation with weight gain. So hypo, think hippo. They have depression, apathy. And they have bradycardia, hypotension, dysrhythmias, and they have myxedema as well. And with the myxedema, you want to look out for myxedema coma, which is where what you would do is you administer an IV of levothyroxine, 0.9, T3 IV. You want to give them glucose, and you want to also look out for their ABC. All right. So some nursing action is you want to make sure you get an EKG or ECG. You want to get a CBC as well. Get a thyroid scan. Have them wear anti-embolic stockings. You want to avoid fiber laxatives, and then report any chest pain. And you want to warm them up. So give them warming blankets, whatever it may be. All right, I think that's it on this side. Take a photo, zoom in, whatever you may need to do. So that's for that. All right, let's move over here. All right, so it might be a little hard to see, but here we got, let's start with UTI. So here we got UTI, right? This is often caused from E. coli. This is a lower UTIs. We got cystitis, urethritis, and then upper pyelonephritis, right? Expected findings, we should already know. Confusion in older adults. They have dysuria, hematuria, which is blood in the urine, cloudy urine, pyuria. They have incomplete emptying, hypotension, tachycardia, tachypnea, fever, all that stuff. And if it's untreated, it can lead to urosepsis or polynephritis. All right, some risk factors would be alkaline urine. Alkaline urine can increase the bacterial growth, right? Same thing with having poor hygiene, wiping back to front. You don't do that. They have stool incontinence. All that bacteria is just hanging around their urethra. So if they have any past urinary conditions, diabetes is a big thing for UTIs. It can cause it. Wet bathing suits for females. Same thing for females. Don't be in bubble baths and hot tubs too long or frequently. And then same thing with sexual intercourse. You want to make sure you urinate. And then let's see, risk factors of that could be incomplete bladder emptying. So that can be in conjunction with interstitial cystitis or whatever it's called. All right, some labs. You want to get a urinalysis, STI testing, and then WBC as well. And the medications, the one that she has for us, she wants us to know is ciprofloxacin. So you want to make sure you take it with food. People can be sun sensitive to it. They can have watery diarrhea, which is a sign of pseudomembrane colitis. I'm not gonna go too deep in it. I just put it down there. And then some things you want to tell them is to drink at least 3 liters of water daily, increase their hygiene, drink cranberry juice, and urinate when they have an urgency. And then over here we have pyelonephritis, which is an inflammation of the kidney pelvis and can lead to scarring, which can be also a sign of chronic pyelonephritis. So, which risk factors? This can be for pregnancy for women that's at 32 weeks gestation. I like to think of it because of the pressure or whatever it may be. Neurogenic bladder, something that they might be born with, congenital malformations. Alkaline urine again. Prostatitis, that was in the ATI practice, so prostatitis and PPH. Older adults with their temp because they have a lower thermal regulation than us. Some expected findings would be chills and fevers. CVA, costovertebral angle tenderness. So if they have that, it's a sign of polynephritis. Same thing with flank pain and hypertension. Some labs, this is pretty easy. They have an increase in creatinine and BUN, increase in ESR and CRP, which is the C-reactive protein, and they have a positive leukocyte esterase. And it's probably gonna be the same thing for UTI as well. They have a positive leukocyte esterase. Some medications, we give antibiotics and morphine for pain. Clinication, same thing, drink at least 2 liters a day, take rest periods from activity, and maintain nutrition. And some complications that can happen with polynephritis would be septic shock, chronic kidney disease because of their BUN and creatinine, and then hypertension because of sodium retention. All right, and then last thing would be the glomerulonephritis. So this is from glomeruli, I can't pronounce it, but it's an injury. It can lead to end-stage kidney disease, and it can happen with the presence of lupus and Goodpasture syndrome, which is where it's an autoimmune disorder that attacks the kidneys and the lungs. All right, so for some expected findings, we can see edema, hypertension, probably because of sodium retention, fluid volume excess, probably sodium retention again, dysuria and oliguria, anorexia, and they'll have a reddish brown cola-colored urine. And then typically this would be derived from strep. So some labs we might see, we have a decreased GFR, which is probably the reason for the hypertension and the fluid volume excess as well. We're gonna get them a 24-hour urine collection, and then their ASO will be increased, which is the anti-strep something, but typically it'll be increased. And then something you want to do as a nurse is conserve their energy, give antibiotics, monitor their fluid electrolytes, monitor the blood pressure, and take meds and increase their hygiene. And you want to make sure that they're not so much around sick people or anything, because they can have an increase to infection. All right, so the last thing would be the nephrotic syndrome, which is literally no blood protein. So they have protein in urine. It's gonna look frothy. So like, you know how she said, if we shake up a milkshake and it looks all that bubble, it look like all those bubbles on top. That's because there's protein in the urine, but no protein in the blood. So they can have weight gain because of sodium retention, foamy urine because of the proteinuria, the flank pain, hypertension, hematuria, hyperlipidemia, and they can be at risk for thromboembolism. Biggest thing, thromboembolism. And then for risk factors, right? So it can be diabetes, lupus, HIV, hepatitis, dealing with malaria and NSAIDs. And the biggest thing is, which we will see, is that people with nephrotic syndrome, they'll have hypoalbuminemia and maybe hypernatremia as well because of the sodium retention. And then some class education that I saw that was important was probably telling them no processed meat because it's high in sodium. So if they already have sodium retention, you want to make sure that they're having a low sodium diet as well. And you want to make sure they're increasing their protein as well. Let's see what else. Treatment. There is no cure, but there is management. So prednisone, it can cause hypokalemia if it is used for long term. You want to make sure you're increasing the protein. You give them statins because of hyperlipidemia, diuretics because of the weight gain and sodium retention, and the warfarin because of thromboembolism to coagulate that blood. So other than that, this is an exam 3 recap of everything that I've thought was super important so far. Hopefully this is helpful to you guys, and let's just do good.